for the introduction, and I'm glad here to share our study on the cardiotoxicity in radiation oncology. So lung cancer is the second most common cancer and the leading cause of cancer deaths in the United States, and the radiotherapy is a common treatment option for lung cancer. However, in recent years, the radiation-induced cardiotoxicity has become a major complication for patients receiving thoracic irradiation. The morbidity can be up to 33% in lung cancer patients. It accounted for 7.4% of the total deaths in a non-small cell lung cancer study involving more than 200,000 patients, which is only secondary to the primary tumor. And the mortality can be even underreported, given that 30% of the patients died out of hospital and were attributed to cancer deaths actually didn't have any documented tumor relapse. Moreover, the cardiac injury is irreversible, so the most effective way to reduce cardiotoxicity is to spare the dose delivered to the cardiovascular system. And the CONTACT has defined the whole heart-based constraints. However, as heart is a heterogeneous organ, the whole heart-based constraints are less informative and reliable, especially in the era of modulation, intensity modulated radiotherapy. So increasing evidence suggests that those delivered to cardiac substructures actually provide superior predictive power compared with whole heart doses, and those substructures include left atrium, left ventricle, left anterior descending coronary artery, the LAD, and cardiac valves. And the figure here shows a general workflow for radiotherapy. After consultation, the patients take CT simulation images, target and organs at risk are contoured, and treatment plans are created based on the prescription and normal tissue constraints, and then radiation is delivered with proper follow-up. However, during the whole process, the understanding of the radiosensitivity of cardiac substructures remained very limited, and no consistent constraints has been found. One of the potential reasons is that cardiac substructure doses can be highly correlated, and not all of the studies cover a comprehensive set of cardiac substructures due to the fact that manual delineation is quite labor and time intensive, and therefore cardiac substructure dose constraints were not yet included in the clinical practice. So in this study, we try to incorporate AI-based approaches to first auto-segment those cardiac substructures, second, to predict the patient cardiotoxicity risk and identify specific substructure constraints, and then re-optimize the treatment plan to reduce the cardiotoxicity risk. The purpose is to establish an end-to-end framework integrating all of the three parts to enable personalized cardiotoxicity management in lung cancer radiotherapy. So for the first part, the auto-segmentation, we curated a total of 142 patients treated in MD Anderson. 100 patients were used for training, validation, and testing. We delineated manually a total of 19 cardiac substructures, including the whole heart, 4 chambers, 6 great vessels, 4 valves, and 4 coronary arteries. Here, contrast-enhanced CT scans were used to facilitate the manual delineation, but were not included in the training and testing. And we remained the other 42 patients for subjective evaluation. We developed 2 deep learning models. The first, a 2-stage localization segmentation 3D unit model as a baseline, since most of the commercial softwares employ this strategy. And second, in-house and unit model, which achieves the sort of performance in medical segmentation task. And we also include a multi-atlas approach for comparison. For geometric evaluation, we use dice similarity coefficient, surface dice, mean surface distance, and 95 percentile Horn stop distance. For dosimetric evaluation, we compare the mean dose and maximum dose delivered to each substructure, and for subjective evaluation, we have 4 physicians score the auto contours on a 5-point Likert scale, with 5 indicating use as is, 4 minor edits not necessary, 3 minor edits necessary, 2 major edits, and 1 totally unusable. So the figure here shows the qualitative results from manual delineation, 3D UNet, 3D UNet, multi-atlas method, and the open Python package Platypy. So visually, the 2 deep learning models outperform traditional methods. And I will skip the details in this form, but I want to highlight that for the dice similarity coefficient, our N unit model achieved a 0.95 for whole heart, 0.91 for chamber, 0.86 for great vessel, 0.81 for valves, and 0.6 for coronary arteries, which is the most difficult part for this task. And the figure here summarizes the subjective evaluation results. In the upper panel, each thin bar represents the physician, and we observe minor inter-observer variability there. And the lower panel summarizes the scores for all the 4 physicians. And if we take 4 and 5 as clinical acceptable, then the overall acceptance rate for this model is 94%. And in comparison with similar studies, our model achieved, like per the publication, our model achieves the best performance in chambers and the LAD among all those non-conscious CD-based studies. And details can be found in our paper published in Radiotherapy and Oncology. So the second part, we focus on the high sensitivity cardiac troponin T elevation, which is a crucial biomarker for early detection of radiation-induced cardiotoxicity. So from the figure here, we can see that the patients with a level change larger than 5 nanogram per liter were associated with significantly higher risk of cardiac adverse event and higher mortality. So the endpoint of this study was set as maximum change of the high sensitivity cardiac troponin T level larger than 5 nanogram per liter. We curated a total of 299 patients treated in eminence, and 225 of them were retrospectively collected, and 74 of them were prospectively enrolled in an ongoing clinical trial. For each patient, they received photon or proton radiotherapy. Informed consent was signed to donate blood samples, and we serially measure the high sensitivity cardiac troponin T before, during, and after the radiotherapy. And after excluding patients who withdraw their consent or lack of enough measurements, we have a total of 160 patients used in the Monte Carlo cross-validation to construct machine learning models. And similarly, 57 patients from the prospective dataset was remained for holdout validation. And we collected the clinical pathological factors for each patient, including the age, gender, race, pre-existing heart disease. All the contours were generated on planning CT using the aforementioned tool. And then we extracted 106 radiomic features from planning CT images. We also extracted 33 dose volume histogram, the DVH parameters, including mean, minimum, maximum dose delivered to absolute and relative volumes, and relative volumes receiving certain dose. And we also extract the same category of features from 3D dose maps and denoting them as doseomic features. And following that, we have a rigorous workflow, including robustness analysis of the radiomic features, univariate analysis to pre-select the significant features, and recursive feature elimination to reduce the number of input features. And the feature importance were recorded in every iteration. For model comparison, we established a clinical baseline model using only clinical factors, and we try to compare the performance of whole heart-based models versus substructure-based models. Among each category, we try to compare the predicted power of DVH parameters, radiomic features, doseomic features, and the combination of all of them. So in total, we have 9 different models. The table here shows the demographics of the patients. So there's no significant difference between the retrospective and the prospective cohort, except that the prospective patients has elder age, less smokers, higher troponin baseline. And it is worth noting that the elevation rate in the 2 groups was almost identical. And in the univariate analysis, by comparing the prospective versus retrospective patients, we identify a significant reduction in the whole heart V20 degree, which represent the effort we spent on reducing the whole heart dose during the years. However, there's non-significant changes in the LAD V20 degree and the LAD D1cc, which were identified as the most significant predictor for the elevation. And in cross-validation, the baseline clinical model achieved AURC of 0.66. There's very marginal improvement in whole heart models. There's significant improvement in the substructure models. The substructure DVH model achieved a 0.71 AURC, and by combining all the input variables, the whole heart hybrid model can also achieve a AURC of 0.7. However, in the holdout validation, the baseline model and whole heart models both fail with AURC less than 0.51, and the substructure DVH model still achieved an AURC of 0.6, which indicate that the whole heart models are less robust across different data sets. And in the feature importance analysis, we it appears that the tumor location was the most dominant feature among the whole heart-based models and clinical models. However, we didn't see that in the substructure model because the substructure DVH parameters inherently has the information of the tumor location. And by using different indices, we can identify the optimal cutoff value for the LAD-V20 degree. So here we recommend the LAD-V20 degree should be less than 0.2% or 5% depending on different matrices. Similarly, for the right ventricle maximum dose, we recommend the maximum dose should be lower than 42 gray or 48 gray. And the third part of this study is the plan re-optimization. We curated 39 patients for this purpose, and we established an automatic workflow to assess the cardiotoxicity risk to create the objective function and re-optimize the treatment plan. So in the first step, we start with the treatment plan and CTs. We get the autoconduits, we generate DVH parameters, and together with the clinical factors, we estimate the cardiotoxicity risk of that patient. So here the risk factors we consider including LAD-V20 degree, right ventricle maximum dose, the age, pre-existing heart disease, and we got this a nice, beautiful mathematical equation from the logistic regression model. And in the second step, we can, for those high-risk patients, by using a neutral threshold probability of 0.5 and the weighting factor omega LAD to balance the input from the LAD and right ventricle, we can easily derive the recommended dose levels for the LAD-V20 degree and right ventricle maximum. And then we create the objective functions and re-optimize the plan. During the re-optimization, we dynamically relax or enhance the constraint, try to achieve an optimal balance between the cardiac sparing and the tumor coverage as well as the other OAR sparing. And this process will be repeated twice, and finally we got the optimized treatment plan. So the table here shows the re-optimization results. The best optimizer here achieve a reduction in the LAD-V20 degree of 15% and a 9-degree reduction in the right ventricle maximum dose. At the same time, there's minor change in the tumor coverage, and all the other organs at risk constraints are satisfied. And the figure here shows the best case where the LAD-V20 degree reduced from 35% to 4%, and the right ventricle maximum dose reduced from 42 degree to 18 degree. The lower figure shows the worst case where there is like minor reduction in the doses, and the performance of this tool actually largely depends on the patient condition. For example, in the best case here, the LAD is located in the center of the two separate targets, and there is enough space for the optimizer to push the isodose lines away from the LAD. However, in the lower case, the LAD is quite close to the mono target, and there is limited room for the optimizer to reduce the dose. However, this is still a very nice tool to inform potential cardiac toxicity for individual patients. And the median re-optimization time is around 4 minutes compared with like hours spent on the planning process, and there is limited increase in the plan complexity. So in conclusion, with a well-curated dataset, auto-segmentation of the cardiac substructures can achieve very high clinical acceptance and can be used to facilitate retrospective cardiotoxicity studies. The findings in our toxicity modeling underscore the predictive power of LAD-V20 degree, and we should carefully handle radiomic and dosimetric features as they seem not to be robust across different datasets. Cardiotoxicity prediction model can be integrated in our treatment planning process for quality assurance aiming to reduce the personalized toxicity risk. Thank you. Questions are very welcome.
Hi, Dr. Chen. Thank you for the excellent talk. Just wondering, what is the definition for the cardiotoxicity in this study? Is it MI, CHF, and what specific time frame was that measured? Like 6 months, 1 year, 10 years?
This is a very nice question. Like essentially here for this study, the endpoint is a biomarker. So we monitor the change of the troponin level in the blood during the treatment. So it's like a short-term, early manifest of the biomarker. But in previous study, we correlate that increase to a long-term, like 2-year follow-up, like where patient has a cardiac adverse event like heart failure coronary artery disease, something like that. Yeah.
I
But
see.
for this purpose, we use a biomarker.
I see. So surrogate biomarker is
Yeah,
the,
surrogate. Yeah.
I see. And would a time to event or survival based model perform any better than a logistic elastic net when it comes to?
We compare
you.
several different machine learning models, and for this data set, the logistic regression net works the best. So that's the reason we picked that.